Well, today, what I'm going to talk about is optimizing cardiac output in the postoperative period. Talk a little bit about arrhythmias in the ICU, and also other ways we have of assessing and optimizing cardiac output in our postoperative patients. So cardiac output is a very simple concept, but it's very difficult to quantify in postoperative patients. If some of you saw the article that I wrote in the nurse practitioner newsletter, there are some indirect ways of assessing cardiac output that we can use in the ICU, mixed venous saturation, etc. But we don't really have a good direct way of doing cardiac output. We've done a couple of times. We've tried to use thermal dilution, where we try to measure cardiac output, and it turns out, especially in young patients, infants in particular, to be very difficult to do, very difficult to reproduce. So our assessment of cardiac output is difficult, but cardiac output is, simply put, the product of the heart rate and the stroke volume. So if you're trying to optimize that number, it makes sense to take it apart into heart rate and stroke volume and say, what can we do to each one of these things to optimize them? And obviously optimizing them in terms of heart rate doesn't necessarily mean maximizing it. It means finding the window that's ideal for that patient. So ideally, if we start with the heart rate component, the ideal heart rate, or the ideal kind of rhythm would be sinus rhythm, or at least some rhythm with atrioventricular synchrony. And what that means is that the atrium and the ventricle are talking to one another. You have atrium contracting at a normal PR interval before the ventricle contracts. So that's true of sinus rhythm, but it's also true of some other atrial rhythms as well, which can still generate an adequate cardiac output. In some patients, you can have an adequate cardiac output without atrioventricular synchrony, but it's less likely that you will. In neonates and infants, what that means is that you want a heart rate that is up to, but probably less than about 190 or 200, because as you get beyond about 200, you lose the diastolic filling time, and although you have enough rate, it starts to impact on the stroke volume side of that equation. So how do we figure out what the rhythm is? Well, there's obviously we can do EKGs, we can hook our atrial leads into the bedside monitor and try to look at them and try to figure out if, number one, what the atrial activity is relative to the QRS complex, if there is atrioventricular synchrony. So I'll start with a case scenario. So we have a 2-year-old hypoplast who comes back to the PCTU after a lateral tunnel Fontan. And when he shows up, the CVP is 15, the LA pressure is 8, the mean arterial pressures are in the low 50s, so not great. So he gets multiple volume boluses. His inotropic support gets escalated, dopamine and epi are turned up. It's at 10 and 0.08. And there's no change. The MAP is still low 50s, and the filling pressures are still about the same. They're not particularly low, so not particularly high. And the ECG shows a narrow complex tachycardia with no P waves. After a Fontan, in particular, jet is one of the rhythms that we have to watch out for, junctional ectopic tachycardia. When we look at arrhythmias postoperatively, I think it's difficult in the ICU always to know what the arrhythmia is, what the precise EP diagnosis is. But the useful thing is that you don't really need to know that in order to treat them. So two things I think from the ICU approach when you look at arrhythmias to take apart are, number one, is this a reentrant arrhythmia or an automatic arrhythmia? What that means is that is there, as in SVT, for example, if there's a circuit where there's a sudden onset to this arrhythmia, it's at a particular rate that doesn't change, and then those kinds of arrhythmias are responsive to shock, usually. Or is it something like JET, which is classified as an ectopic or automatic tachycardia, where it gradually, you see in 150, 160, 170, it gradually heats up and gets up to the high rate, 190 or 200 usually. And the rate varies a little bit, and in those cases, you need other means to bring that down. Shocking them is not necessarily going to help you. I think that is number one, the most important thing. And then number two, obviously, the usual things like is this an atrial rhythm, is it a ventricular rhythm? And you can tell that usually by the width of the QRS complex. Most importantly in the ICU is if there is an abnormal rhythm, is the most important question is the arrhythmia actually causing the hemodynamic problem? There are going to be a lot of patients who come back from surgery who have an arrhythmia where it's a tolerable arrhythmia. It's not necessarily responsible for anything. Just leave it alone. One thing that everyone I think around here is very good about doing is immediately checking and correcting electrolytes in the context of any of these arrhythmias, in particular mag, potassium, and calcium. And then try to make some interventions on those. So for bradycardias are actually fairly simple to deal with in the ICU because there's not that many causes. You can either have a sinus brady or a non-sinus brady, and the only non-sinus bradies that really matter for the ICU are the heart blocks. So second-degree heart block or third-degree heart block. Typically, we have pacing wires, and we can deal with that. Sinus brady is a little bit trickier because you have to identify what the underlying cause of that sinus brady is. Is it something that's activating vagus pathways, as simple as an ET2 hitting the carina? Is it something that's activating a cerebral reflex, like bleeding with increased ICP? Is it a medication effect, something like dexmedetomidine or some of the other medications we use will directly cause sinus bradycardia? So that one's a little bit trickier because you have to figure out what the cause is. But still, even if you don't, you can still pace that typically fairly easily. The tachycardias turn out to be a little bit tougher, and those are the ones where we really spend the most time trying to figure out what to do. As we talked about, if you can identify something that's sudden onset at a fixed rate, that's typically something that will respond to either adenosine or shock. Adenosine can be used both therapeutically and diagnostically. A lot of times when we have a rapid narrow-complex tachycardia, we don't have a good way of telling whether that is what we call a reentrant SVT or an atrial flutter. And we'll use adenosine then both diagnostically and therapeutically. If it's a reentrant SVT, it should cause sinus rhythm again. And if it's a flutter, it should just cause enough of a break in AV conduction that you can just see the series of flutter waves coming through. So it's useful that way. There's a term called overdrive pacing. That's a term that I don't really like because it's not really precisely defined. People have different concepts of what overdrive pacing really is. So I think it's best to describe exactly what you're doing when you're pacing someone. The way I see it, there's really two uses for pacing in an arrhythmia. Number one would be you have a jet rate, let's say that's in the 160s, and the patient's blood pressure isn't that great, and you want to set a sinus rate that's faster than that. So you can pace the atrium at 180, and then you'll have a sinus rhythm. It'll be kind of fast, but you have a sinus rhythm, and oftentimes patients will have a better blood pressure as a result of that. Some people refer to that as overdrive pacing. There's also what's called rapid atrial pacing to terminate a reentrant arrhythmia. So in the SVT type case where you could use adenosine or shock, in those patients with atrial wires, you could also pace for 10 seconds at 350 per minute, and oftentimes that will break the arrhythmia permanently at 10 times. Some people refer to that as overdrive pacing too. So honestly, I don't know what they mean by overdrive pacing, but those are the two types of pacing that we'll typically use. Cooling is another thing that's useful for these. So most of these tachyarrhythmias are temperature responses. And our patients often after an operation are a little bit on the warm side, and even if they're normal thermic, can benefit from being cooled to kind of the 34, 35 range. I'm sure a number of you were here a few years ago when Brendan Kelly was a fellow and did a study on really unaggressive cooling for jet, but it does work. He did a small study in post-operative jet, and we had to get patients down to a mean of about 33, but we were actually able to convert jet to sinus rhythm in the majority of patients by getting them down to about that. The trick in that, I think, is that it's difficult to get some patients that cool. And the bigger the patient is, the harder it is to get them down. So infants weren't that hard to cool, but adult-sized people were incredibly difficult to cool down there, especially if they were starting out at 39 or 40. It was basically impossible. But cooling can be useful as well. Antiarrhythmics are really a topic of another talk, so I'm not going to go too far into antiarrhythmics. But the critical ICU antiarrhythmic really is amiodarone because it works in so many different mechanisms for treating tachyarrhythmias. The side effect is really that it can cause bradyarrhythmias, cardiovascular collapse, and hypotension in some cases, as we saw a few hours ago. So, catecholamines, so dopamine, epinephrine, etc. Those drugs are obviously ones that we use typically in our patients. But if you have a patient with a tachyarrhythmia, one of our goals should be to try to decrease those as much as possible. So that's a setting where using vasopressin as a blood pressure support agent makes more sense, especially if you're able to bring down your dopamine and your epinephrine. So often in the Fontans and in the Tets who are at risk for jet type arrhythmias after surgery will preferentially go for vasopressin to try to avoid driving those arrhythmias. Cardioversion we talked about. And then an interesting one is dexmedetomidine. So dexmedetomidine is a combination sedative analgesic agent that we're using obviously quite often in our postoperative patients, but it has some use as an antiarrhythmic as well, and there's been a number of abstracts published in the last 5 years about the use of dexmedetomidine in the ICU for postoperative tachyarrhythmias, and at doses of about 0.8 or 1, it's been able to, in a few small studies, break most SVT type rhythms, or at least bring them down to manageable rates in the majority of patients. So we'll often think of using that as an adjunct where you want to achieve some sedation and analgesia, but also for patients with tachyarrhythmias. The downside of dexmedetomidine is if you have an infant that's starting with a sinus rate that's on the low side anyway, then that's going to get worse because it's going to lower that as well. So, usually, I think in our stable infants who are going along even at 90 or 100, bring them down to 70 or 80 with dex doesn't harm their cardiac output very much, but it's something that we need to watch out for. The other side of cardiac output is really the stroke volume. So the stroke volume side is a little bit more complicated. So the three classic determinants of stroke volume that we can work on if we're trying to optimize stroke volume are preload, afterload, and contractility. We talked about heart rate and getting the heart rate into a good range and getting the rhythm controlled, but this is a little bit more complex and probably a little bit more variable. So to optimize someone's preload, it's critical to know what the diastolic properties of that heart are. And that's something we don't always know. So if someone comes back from the OR and has a CVP of 5, for example, and is a little bit on the hypotensive side, the rhythm is sinus, in most of those cases we know that that's a little bit on the low side. Probably that RV wants a diastolic filling pressure that's a little higher than that, so we give but if it's 8 or 10, it's a little bit more challenging to figure that out. And it really depends on that particular patient's RV. What is the diastolic property of that RV? Does it require 8 to fill adequately and to generate a cardiac output? And similarly on the left side, the LV, we have even less information because we often don't have an LA pressure and we don't know the LV diastolic properties at that time. So sometimes it's helpful in those cases to have had the cath numbers, if they were caths prior to surgery, to know, at least in a general sense, is this a stiff heart, meaning it requires high diastolic filling pressures in order to generate adequate output, or is it a not particularly stiff heart? That being said, the fact that you are on bypass after your cath changes everything in some cases. So a lot of times you just don't know. So the issue of deciding on volume versus diuresis ends up being very difficult. And oftentimes we end up doing both, just saying, all right, we're going to tank up and we're going to get diuretics. In that case, having RA and LA pressure monitoring can be helpful. The issues of colloid versus crystalloid, lots of studies, no universal agreement, probably doesn't matter. If the patient has a low total serum protein or total serum albumin, then using albumin makes sense. If they're also
coagulopathic, then using FFP as a volume expanding agent makes sense. And if they're anemic, using blood as your volume expander makes sense. But it probably doesn't matter that much. It's really about filling the tank. The other thing in optimizing preload is finding any impediments to filling. So depending on what surgery's been done, if there are venous baffles that could be obstructed, for example, then knowing about those. So in patients with, in particular, Fontanes or Senning type procedures, Senning Mestelli or double switch procedures, you can have a CVP that's adequate because you're measuring it, let's say, up in the neck, but then there's a baffle that goes from here over to the AV valve, and if that's obstructed, then the pressure is fine up here, but it's actually low distal to that obstruction, and you don't necessarily know that. So thinking about that, and then evaluating early on with echo or cath to find out if there are baffle obstructions makes sense. Other impediments to filling, pericardial fluid. So if there is significant pericardial fluid or any tamponade, then obviously relieving that. And pneumothorax, really for the same reasons. Let's see, we talked about albumin. Really, and for albumin, the goal is to me, to get it above about 2.8 grams per deciliter. Above that, it doesn't make much sense to keep giving more high, like 25% albumin, to try to drive it higher. That seems to be enough to minimize interstitial edema and third spacing. Postoperative Lasix is very controversial, how to give it and when to give it. There's not a lot of studies really looking at postoperative Lasix. We use a lot of it, but there's not a lot of data about it. The continuous versus intermittent is highly variable from institution to institution. If you go to Boston and you come out of surgery and you get started on Lasix, you get started on a drip. You don't get started on intermittent Lasix. And we do intermittent Lasix. And the one study I found looking at intermittent Lasix versus drips showed really that there's not that much difference in the overall urine output or the amount of Lasix required to achieve that urine output. So it probably doesn't matter that much. Next case. So we have a 3-month-old with Tetralogy who was transferred in from an outside facility. Baseline sats are 65. He's not been repaired. He starts to have spells with sats in the 20s and 30s. So he's intubated, he's sedated, he's on 100% oxygen. He's got arterial and central venous catheters in place. So what are we going to do for this guy? What's the inotropic or pressure support strategy? So sometimes it can be useful to try to titrate your inotropic or pressure support. In this case with Tetralogy and TET spells, what we're going to try to do is really clamp down the systemic vascular resistance. So we talk about pressors. Most of the agents we use are really kind of inotrope/pressor agents. But in this case, in the TET case, we want to use pure pressor agents. So for afterload, if you want to directly increase afterload, then you want to use a pure pressor agent. And the two that we use are phenylephrine and vasopressin for that action. If you had, let's say, a case, a patient with a cohort that's unrepaired and sort of has moderately decreased function, which we often have when they come in from the outside with having either arrested or near arrested and their duct was mostly closed, then in that case we want to use an agent that has more inotropic support action. So what we use there is epinephrine, dopamine. And then if you have a patient who's let's say a hypoplast pre-op who's got sats up in the high 90s and is very overcirculated and is getting a high lactate, what you want to use in that case is what people refer to sometimes as an inodilator like milrinone, where you have inotropic action, which is good for a systemic RV, but you also have a decreased systemic vascular resistance, so the opposite action of something like vasopressin or phenylephrine. So titrating for afterload, really you have to titrate the choice of agent to try to understand what the hemodynamic situation is and titrate it. And the other side of afterload is sometimes it's too high. So we have patients that come back after, like especially teenagers, Ross's, aortic arch replacements, reconstructions. They tend to have hyperdynamic LV function, and they come back with blood pressures in the 140s, 150s, 160s, and the surgeon's going nuts because they just did this big suture line on the aorta, and we need to have the pressure lower. So in that case, you want to use a pure vasodilator, and the choices of those, typically what we use is esmolol, but also nicardipine or nitroprusside. The esmolol and nicardipine have a little bit of negative inotropic action. So if you're hyperdynamic, that's fine. If you actually have hypertension with decreased function, then you need to watch out for those agents, because they can depress cardiac function directly.
We got about 5 minutes left, Ron.
Okay. All right, one more case scenario. So 3-week-old with truncus, who's just got repaired. He's had a long procedure. He required a second bypass run because the truncal valve didn't work. It had to be replaced with a homograft, and he comes back on ECMO. So he's got flows that are adequate, mean pressures that are kind of marginal, mid-30s. He's on dopa, epi, and vaso, and on full ECMO support, and he's an oliguric. He's comes back. He's not peeing much. His weight goes up, so he gets placed on filter. And what do we want to do for this guy now? He's requiring fairly high inotropic support. So in that case, what we usually reach for is steroids. Again, not a lot of data supporting. There are some studies, including one that Rob Gierski did here. Steroids, certainly if you're suspecting adrenal insufficiency and you have any evidence of adrenal insufficiency, then replacing with steroids. But we often use hydrocortisone, stress dose as or nothing else is really working, type agent. So that's a kind of typical and can be helpful. IV thyroid hormone was in some favor about 10 years ago, but really no good data, no good evidence, not really in use much anymore. The other thing about afterload and inotrope suppressors is that the blood pressure doesn't always tell the whole story. So we have a number, but not treating that number is not necessarily what we need to do. So it's important to keep in mind treating what we're really treating. So we're trying to ensure cardiac output and adequate organ perfusion. Something like lactate can tell you a lot more about that, because that's actually telling you from the tissue side, are the tissues adequately perfused or not. So if you have a patient that's got a blood pressure that's 5 lower than what you're aiming for, but they continue to pee and have a lactate of 0.5, then that's okay. That's you're getting them what they need typically. As long as there's no signs of any organ, like the brain, or any organ that seems to be starved, that's okay. The other the indicator that's helpful to talk about is the VIS, or vasoactive inotrope score. So what we define here is a score called VIS or VIS to quantify what our support is. So it's just an index where you just take the amount of dopamine and the amount of epi, norepi, noradrenaline vasopressin, you basically add it all up. So you turn it into a regular number. So for dopamine, you just the number. For epi, because it's like 0.05, you multiply it by 100, so that becomes 5. For vaso, because it's so many zeros, like 3 becomes 3. And so you just add all those numbers up, and that can tell you overall how much support is this patient on. Michael Gaze did a study here to showed that a maximum VIS of more than 20 in the first 24 hours was associated with poor outcome, and the median maximum VIS for our infants 0 to 6 months was 13. And the higher it was, the worse their potential outcome was, which makes a lot of sense. The other things to think about and kind of the afterload side is sedation and analgesia and what the effects of that are. So morphine, Versed, Propofol can all lower your systemic vascular resistance. Ketamine is a useful agent that doesn't do that. So thinking about what the possible side effects of the sedatives are. And then as far as contractility, we talked about a little bit with the inotropes. The other agents, kind of miscellaneous agents we can think about. Calcium chloride can be helpful for driving up the ionized calcium. It's indicated obviously in hypocalcemia. It's a little bit controversial in normal calcemia, but we certainly give it and use it. And then obviously trying to normalize the serum pH. So to maximize cardiac efficiency, so using bicarb fairly aggressively here to try to get the pH into the 7.35 to 7.45 range. A useful, on the base deficit on the blood gas, giving 1 milliequivalent per kilo of bicarb for every -3 in base deficit turns out to work pretty well, so that's usually what I end up using as a rule of thumb. And then finally getting an echo if you're not really supporting them, or getting a cap and pushing on with more investigation if it's really not working well. That's pretty much all I have.